First, let's welcome Dr. John Rommel, a heart failure specialist with Novant Health Heart and Vascular Institute in Wilmington. Welcome to the show today, Dr. Rommel.
Thank you for having me.
So nice to have you here. So you specialize in heart failure, correct? Well, tell me what that means. What is heart failure?
Yeah, so heart failure is a term that, to be honest with you, sometimes is easier to see in someone, and it's one of those diseases that you know it when you see it, but at its core what it means is for one reason or another, the heart is not able to keep up with the demands of the body. And so the heart is not able to get blood to where it needs to go, and that can happen for a variety of different mechanisms.
I think I understand that. And is there a cure for heart failure?
Unfortunately not. Heart failure is a progressive disease. We can temporize it, we can stabilize it with medicines, with procedures, with devices, but ultimately it will continue to progress in most of our patients.
Wow, that's sad. Tell me about risk factors for heart failure.
Yeah, most of the risk factors for heart failure kind of fall in line with just general cardiovascular risk factors. So hypertension, diabetes, high cholesterol. Developing heart failure beyond that, history of coronary disease, obesity. As we get older, we can also sometimes see an increasing prevalence of heart failure. You know, we see it in our patient populations between the ages of 60 and 65. About 5% of our patient population will have it. Over the age of 70, it's as high as 10%.
Wow.
Yeah, but it can affect all age groups. But you know, again, as patients are living longer and doing more and getting their other diseases treated, we are starting to see an increasing prevalence of heart failure as a result.
Well, I read that, excuse me, heart failure is projected to be on the rise. Is that right?
Yeah, it actually...
How did you know that?
Yeah, the WHO actually called it an emerging epidemic back as far as 1997. It's something that we've seen just, again, because we are living longer, we are having other medical problems pop up, and as a result, sometimes these impacts affect the heart as well. And so we've seen it kind of across the country that the rates and prevalence of it just continue to kind of slowly trickle up everywhere.
Well, what are some of the treatments for heart failure?
Yeah, so the first thing we always approach is guideline-directed medical therapy, and usually nowadays we're talking about kind of four main pillars of treatment, which is beta blockers, which is medicines like you might see on TV like Entresto, spironolactone or aldosterone antagonists, and then a newer category that's kind of come to prevalence in the last few years called SGLT2 inhibitors. They're diabetic medicines that we've now demonstrated benefit, and if you don't have diabetes, just heart failure, you can still see the benefit of these medicines, and that's the commercials you might see on TV are Jardiance, Varziga, along those lines.
Yeah, there's so many advertisements on TV that I don't know who they're aiming them at, because I can't see myself walking into a physician's office and saying, I want to take Varziga. Well, I don't even know what that's for. But
it's true, but to be fair, some people do ask it appropriately, and it comes up more often than you think, and you know, I think it always leads to a good, positive conversation about what is and isn't appropriate medical therapy for our patients.
Yeah. Well, today I want to talk about one of the newest treatments that's on the horizon here, the mechanical heart pump.
Yeah, so this is...
I think it's got another name.
Yes. So it's called an LVAD, a left ventricular assist device, or specifically the one we'll be implanting in Wilmington is going to be called the HeartMate 3. And now this is reserved for people with advanced end-stage heart failure. So across the country, that's about 500,000 to 600,000 people a year. These are for people that have a weak squeeze of their heart for any number of reasons, and essentially medications and our standard therapies have started to fail them. So despite optimal therapy, despite optimal effort, we're seeing their heart just not able to keep up with the demands of their body. And for a group of patients in this category, for some people they qualify for this mechanical heart pump, which is a way to help them feel better and live longer.
So is it kind of like the last step?
Potentially, yeah. So when we cross this area, we consider this area advanced therapies. And when you talk about advanced therapies, the two major ones you talk about are heart transplant and left ventricular assist device. And obviously the problem with heart transplant is it's a limited resource, right? We've done a lot of remarkable things in the last decade, increasing the number of organs available for patients, but not everyone's going to be able to get a heart transplant. And a VAD can represent a very reasonable alternative solution for people who aren't candidates or don't want transplants, as a way, again, to feel better and live longer, which is our goal, right? Is to not just be...
Yeah, it's quality of life.
It's quality of life and life expectancy. It's together, you know? It's getting back to work. It's being able to go, you know, ride your motorcycle. It's going to play golf again.
Or fish or whatever. Sit and read a book.
Exactly.
Well, let's talk about that model, this multidisciplinary program that you have.
So actually celebrating our 10-year anniversary, back in 2013, we started what was called the Heart Strong group in Wilmington. Before we were part of the Novant family. And that is a group of nurse practitioners, nurses, pharmacists, myself, case managers that work towards trying to help our heart failure patients get on the right therapies. And that might mean meeting them wherever they are on their journey. Sometimes it's very early and it's getting them on guideline therapies. Sometimes it's late and it's talking about transplants and VADs. And sometimes it's talking about end-of-life discussions, the hard conversations that we know we all have to have.
Right.
And the group's been fantastic. It's been a pleasure. I joined back in 2016, so the group was actually started by two of our APPs. And
wow, that's interesting.
it's been great. And it went from, I think, 2-3 patients a week to now we see about 1,000 patients annually.
Wow, that's truly multidisciplinary.
It really is, and it really takes all of us to make it work and move forward. It is amazing, and our whole team is just phenomenal.
That's great to hear. We can so use those services here locally in Brunswick, Columbus County, New Hanover County. That is one big area, and of course. NHRMC is our tertiary care facility of choice. We send all our patients there, and we're so thankful we have people like you there treating our patients. So I understand there was an accreditation that just happened.
Yeah, so
that's pretty exciting.
It was awesome. So most recently we got accredited just for DNV accreditation to start our VAD program, so the therapies we were talking about earlier. But about a year ago we actually got ACC heart failure accredited, and I think we were the third in the state to get that. Again, I think just kind of demonstrating our commitment to getting our heart failure patients on the right therapies and doing everything we can to try to treat them, keep them here in the community so they're not having to go hours and hours down the road to receive high quality care.
Right. That's hard on families. It's hard on the patient, but it's also hard on families when they have to go outside of this area for care. And really, in today's arena, that's not necessary anymore. We have pretty much everything they need right here.
That has been my goal since I joined here, was to get them what they needed here, and because it's not one single trip up there, never again. These are
it's
multiple times and sometimes weekly visits. And the more we can have our patients, as I like to say, sleeping in their own beds, the better off we're all going to be. So
everybody's better when they sleep in their own beds.
Yes, agreed.
Well, I can't thank you enough for being here today. I hope you'll come back because I can see so much on the horizon here that there's going to be lots to talk about. So will you come back?
It'd be my pleasure.
Great. Thank you so much.
Thank you.